the chat box already. We want to meet your ECMO team, so please send us a picture of your ECMO team. We are going to have a small video to open the session on next Thursday with all the ECMO teams around the world, so we are going to be happy for that. We have a new series that is going to start. Dr. Mary Cohen is going to talk to us about ECHO. So she's going to start this July the 13th, talking about AVSD. And we have other meetings scheduled, and we are going to keep this information on our social media. And we are going to have with Dr. Silverman a series comparing images and the morphology. We had the first one with the truncus, and then the next one is going to be in August, talking about transposition. And today we are happy to continue the series with Dr. Anderson. We are going to talk about AVSD, and we have more to come for you. Please keep with us and keep an eye on the social media so you can know about all the activities. So here you have Dr. Robert Anderson. It's always a pleasure to have you. Thank you so much. Congenital Heart Academy is very proud to have you, Dr. Anderson.
Well, thank you very much, Grace. It's a pleasure to be with you all. And it's wonderful now what we can achieve with Zoom. So it's great to see all the activities that are taking place under the auspices of the Congenital Heart Academy. And those of you who have been watching our series will know that last week we discussed atrial septal defects. And what I did was I related the lesions that produce interatrial communications to the developmental background. And I hope that many of you also took part and participated in the webinars that we did in our first series where we discussed cardiac development. So today I'm going to take a similar approach, and we're going to look at what I like to call atrioventricular septal defects. They used to be called atrioventricular canal defects, and those of you who are watching carefully will notice that Merrill still calls them atrioventricular canal defects. Dr. Silverman, on the other hand, who, as you all know, is a very close friend of mine, and many of the pictures that I will show you today, Norman will be correlating with his images. He'll also be showing you many of the pictures taken by Diane Spicer. In fact, I will also today be using several of Diane's pictures, and Norman will put it all together. So over the next 3 weeks, you're going to get an overview of these lesions, and I am going to introduce it today and put it into the context of cardiac development, and then show you how the understanding of cardiac development gives you the appreciation of what I think is best termed atrioventricular septal defect. We have pre-recorded this presentation again, so Sasha has done a great job in pre-recording my presentation for you. So now I'm going to hand over to Sasha to show you the recording, and at the end, we will have a question and answer session. So over to Sasha, and let's look at atrioventricular septal defect. Well, good afternoon, ladies and gentlemen, and welcome to our next classroom on septal defects. You will all be well aware by now that the normal heart has atrial, atrioventricular, and ventricular septal components. And you all know from your own experience that each of the components can be deficient when the heart itself is congenitally malformed. In our last classroom, we discussed interatrial communications, and I showed you in detail the anatomy of the atrial septum, and we discussed how many of those defects were in fact outside the confines of the septum. Today, we will be discussing atrioventricular septal defects. And then next week, we will be recording a presentation on ventricular septal defects. But for now, our topic is to consider the phenotypic features of atrioventricular septal defect. So if we are to appreciate what is going on with atrioventricular septal defects, we need to come back and we need to look again at the anatomy of the normal atrioventricular septum. Well, we call it the atrioventricular septum because it interposes between the cavities of the left ventricular outflow tract and the right atrium. And on occasions, part of that normal septum can be deficient so as to permit shunting of blood between the left ventricle and the right atrium. And in that setting, there are separate atrioventricular junctions. And these are the so-called Gabodi defects. Now, for the majority of this presentation, I'm not going to be discussing Gabodi defects, but I need to introduce you to these lesions because we have to appreciate that on occasion, there can be shunting between the left ventricle, right atrium, in the setting of separate atrioventricular junctions. And exceedingly rarely, that can be direct. Much more usually, it is indirect. And we know about these Gabodi defects from this presentation, which appeared a long time ago now. Frank Gabodi, the surgeon who worked in San Francisco, drew our attention to these two types of lesions that permit shunting between the left ventricle, the right atrium. So let's look at the normal atrioventricular septum, and it is very small. We see it here in a 4-chamber cut made by Diane Spicer, another of her beautiful pictures. So there you can see the oval fossa. And when we were discussing atrial septal defects, we discussed that the so-called septum secundum was no more than an interatrial fold. If we look anteriorly, we see the anterior intraatrial wall and then a bit of epicardial fat. And in front of that, we see the non-coronary sinus of the aortic root. And that shows us the location of the normal membranous septum. But if we then look at the hinge point, tricuspid valve, we see that in this particular heart, the location of the hinge point divides this membranous part of the septum into an interventricular component. And we'll discuss that next week in detail when we talk about ventricular septal defects, because the commonest ventricular septal defect is perimembranous. The myocardium is deficient around this area of the septum. But here, in this particular heart, there is a small part of this membranous septum that is located in atrioventricular position. And it is this part that is deficient in the so-called direct Gabodi defect. More usually, however, we see left ventricular to right atrial shunting when there are separate atrioventricular junctions in this situation, when we have a perimembranous ventricular septal defect. But if then the leaflets, tricuspid valve, are deficient in the environs of the septal defect, it is then possible to have shunting from the left ventricular outflow tract into the right atrium. And this is the essence of the so-called indirect Gabodi defect. Very rarely, however, we can have a deficiency of that atrioventricular component of the membranous septum. And this we find when the other septal structures are intact, separate atrioventricular junctions, and with a competent tricuspid valve. I have never seen such a defect in the congenitally malformed heart, but my good friend Carl Backer, working at Lurie Children's Hospital in Chicago, described a series of these hearts, and by insufflating in the operating room the tricuspid valve, showing it to be competent, he proved that these were deficiencies at the site of the atrioventricular membranous septum. So if we consider the Gabodi defect, then the indirect defect is really a ventricular septal defect. The direct defect is indeed a true deficiency, the atrioventricular component of the membranous septum, but it is exceedingly rare. So nowadays, when we are talking about atrioventricular septal defect, we are talking about those hearts which have, as their phenotypic feature, a common atrioventricular junction. For a long time, they were known as atrioventricular canal defects. And as I'll show you, there is nothing wrong with that term because they are indeed persistence of what we see during development, the common atrioventricular canal. And they exist when the heart is congenitally malformed because that common atrioventricular valve canal has never been septated. There has never been formation of that membranous part of the septum, nor of the muscular atrioventricular sandwich, which is present when there are separate atrioventricular junctions. So last week, when we looked at atrial communications, I took you through normal development, and I showed how abnormal development led to these lesions. So can we do the same thing in the setting of atrioventricular septal defects? And I believe we can, because now we have a firm knowledge of cardiac development that permits us to make inferences about the morphogenesis, and the changes we see during normal development also help us to understand the heart when it is congenitally malformed. So if I go back now and I show you this episcopic section, this is from one of the data sets prepared by my collaborator Tim Mohan using the technique of episcopic microscopy, it's showing us a human heart at Carnegie stage 14. This is about 5 weeks of development. And you'll recognize, I hope, the right atrium, the left atrium, which are dominating the scene at this stage. They are not yet septated, but there we see the myocardium of the atrioventricular canal. And the key point at this early stage of development is that the atrioventricular canal connects only to the developing left ventricle. There is a right ventricle already at this stage, and it supports the outflow tract. So in the ventricular loop at this stage, the inlet comes from the atrial chambers, the outlet to the outflow tract. And we can make a reconstruction, as you see here. So this is one of the reconstructions made by my other collaborators, Wout Lammers, Jill Hickspoors, who are working in Maastricht, and they've produced these magnificent reconstructions of a whole series of normal human embryos. So here I'm showing you the atrioventricular canal, the ventricular mass, and the outflow tract. And in yellow, they have colored in the location of the atrioventricular canal myocardium. And you're looking at it from above and from the right side. And so what you see, as I showed you just a moment ago, is that the atrioventricular canal at this early stage connects only to the developing left ventricle. There is a right ventricle. So there you see the developing apical component of the right ventricle. And the right ventricle is supporting the outflow tract, which itself is a common channel at this early stage. But what Wout and Jill have also done in this very nice reconstruction is they have shown you the presence of these two masses of mesenchyme that we call the atrioventricular cushions. And they are guarding the entrance from the atrial chambers to the left ventricle. And one is positioned superiorly, the other one is positioned inferiorly. And there are extensions from these atrioventricular cushions into the atrial component of the heart, and they merge together in the roof of the atrium where they are confluent with what we call the mesenchymal cap. And I'll show you the mesenchymal cap in just a moment. It's on the leading edge of the primary septum, which at this early stage is just beginning to grow from the atrial roof towards the atrioventricular cushions. The atrial component of the heart itself remains connected to the pharyngeal mesenchyme at this stage by what we call the dorsal mesocardium. We discussed the dorsal mesocardium in the setting of atrial development, and we can think of it as the heart stalk. And what I'm going to show you in just a moment is that tissues from the pharyngeal mesenchyme grow into the heart through this dorsal mesocardium, specifically through the rightward side of this connection between the developing heart and the developing pharyngeal mesenchyme. So this is the early stage of development, and this is the primary atrial foramen. And in normal development, that will close. Now we can look at a comparable situation in the mouse embryo. So this is about the same situation, the mouse embryo during embryonic day 11.5, which is more or less equivalent to Carnegie stage 14. And what I've done in this data set, which is another episcopic data set prepared by Tim Mohan, is I've sliced off the apex of the ventricular loop. So you are looking towards the base of the ventricular mass from its apex. And so there you are looking at the base of the left ventricle. You're looking at the atrioventricular canal from the ventricular aspect. And there within the atrioventricular canal, you see these two cushions. And you see at this early stage, they have a solitary zone of apposition between them. They open and close, and they are acting as a valve at this early stage of development. And what you've already also seen is that at this early stage of development, effectively, the atrial chambers connect only to the developing left ventricle. So essentially, we have doubling of left ventricle. The outflow tract arises exclusively from the right ventricle. We have effectively double outlet right ventricle. So if the heart is to develop further, one of the things that the embryo has to do is to expand the atrioventricular canal such that the developing right ventricle achieves its own inlet. And we see that occurring later during Carnegie stage 14. As I say, this is around 5 weeks of development. This is graded at the same stage, but the embryo has moved on in this stage compared to the one that I've already shown you. There has been that expansion of the atrioventricular canal such that right atrium can now look directly into the developing right ventricle. This time I'm showing you a 4-chamber cut through this episcopic set. And within the atrioventricular canal now, you can see the two cushions. You see that they lie edge to edge. One is positioned inferiorly, one is positioned superiorly. But within the atrial chambers, we still have this communication between them, the primary interatrial communication, the primary foramen. So if we move on and we look at a later stage, we can see how the embryo is closing this primary interatrial communication. I'm showing it to you in a similar aspect. You're looking at it from the right side. It's another of the reconstructions made by Wout Lammers and Jill Hickspoor. And again, they have colored the atrioventricular canal in yellow. But now, because of that expansion of the atrioventricular canal, you see that the yellow atrioventricular canal myocardium has a direct connection to the right ventricle, but the right ventricle still supports the exclusive outflow tract. Within the outflow tract, however, there are further cushions, and those cushions will eventually come together and they'll divide the outflow tract into the aortic and the pulmonary channels. But if we look into the atrioventricular canal, we can see again superior cushion. We can see how it's lying edge to edge with the inferior cushion. But then if we look at the location of that mesenchymal cap and the primary septum, we see that it has grown towards the atrial aspects of those cushions thus reducing the size of the primary foramen. If you also look at the purpley tissue, you see that there has now been growth from the pharyngeal mesenchyme into the cavity of the heart as a spiny entity, and we call that the vestibular spine. And we now know that it is the vestibular spine that is the key to separation of the atrioventricular junctions. So here we see another picture of the vestibular spine, and this is an important one because this comes from the back end of the 19th century. This is our rendition of a drawing that was made by Wilhelm His. I showed it to you before when we were talking about atrial septal defects. His described this in the middle part of the 19th century, and there you see he has drawn it growing into that space between the primary atrial septum and the atrioventricular cushions. He called it the spina vestibuli, so we've translated that as the vestibular spine. And if I show you histologic sections at the stage I showed you just a moment ago in Wout and Jules' reconstruction, Carnegie stage 16, I hope you can now recognize very nicely the four-chamber arrangement of the heart. You see that at this stage, the right atrium now has its direct connection with the developing right ventricle. And we see how the primary septum, with its mesenchymal cap, has now grown almost to touch the atrioventricular cushions so as to close the primary foramen. And this is normal development. If I take a section from the same embryo, just a little bit inferior, we can then see the growth of that second component into the heart from the pharyngeal mesenchyme. I'm now cutting through the inferior atrioventricular cushion, and there you see the tissue that has grown into the heart, further mesenchymal tissue, the one that was described by Wilhelm His the Elder, and this is the vestibular spine, and it reinforces that fusion between the primary septum and the cushions so as to separate the atrioventricular junctions. And we can see very nicely that function of the vestibular spine in this later stage, again, a reconstruction made by Wout Lammers, Jill Hickspoors. This time I've taken away the atrial chambers so that you can look down now on the atrioventricular junction. Again in yellow, they're showing you the atrioventricular canal myocardium. You see very nicely now that it is separated, so we can see the orifice that's pointing directly into the right ventricle. You see that the atrioventricular cushions have fused. The line of fusion between them is at right angles to the ventricular septum, and that is important. But equally important, the vestibular spine has anchored the developing primary atrial septum to the atrial margins of the atrioventricular cushions, thus giving us separate atrioventricular junctions. And it is this role of the vestibular spine growing in from the pharyngeal mesenchyme that we now know is the key to producing separate atrioventricular junctions as part of normal atrioventricular septation. So the growth of the vestibular spine is the key to normality. And we now have strong evidence to show that the morphogenesis of atrioventricular septal defect with common atrioventricular junction is lack of growth of that vestibular spine. Because amongst the very many episcopic data sets prepared by Tim Mohan, we have found 4 in otherwise normal mice that have retained the common atrioventricular junction. This is one of them. I'm showing you this from the left side. This is a wild type mouse at embryonic day 16.5. And by this stage, the septal structures should be intact. But there you see the remnant of the superior cushion, which is now becoming a valvar leaflet. There is the remnant of the inferior cushion, again molding to form a leaflet of a common atrioventricular valve. But you see that the inferior cushion has fused with the crest of the muscular ventricular septum. And this is another important point that I will be emphasizing very shortly. The superior cushion has also fused with the septal crest, and at this stage, the aortic root is now within the left ventricle. But what you see, if you look at the atrioventricular junction, is that the primary septum has not fused with that scooped out ventricular septum, leaving us an atrioventricular septal defect. And that is because the thing that is missing is the vestibular spine. And now when we look at the atrioventricular junction from beneath, we see that the atrioventricular valve within the left ventricle has retained the arrangement we see during development, despite the fact that the aortic root is now committed to the left ventricle. Because this is what we see earlier in development in the mouse heart. This is at the stage while we still have the primary interatrial communication. And there you see the superior cushion, inferior cushion. There is a lateral cushion formed within the left atrioventricular junction. And at this stage, unequivocally, we have a trifoliate valvar entity guarding the left atrioventricular junction. And that is also going to be key when we discuss the phenotypic features of atrioventricular septal defect with common atrioventricular junction. Now, this is another of those 4 allegedly wild-type mouse hearts in which we have found an atrioventricular septal defect. So this is at 18.5, just prior to what would be birth. And beautifully, you see the primary septum. It has its mesenchymal cap that has muscularized, but it has failed to fuse with the atrial aspects of the cushions. There is persistence of that primary interatrial communication. Also, however, there is a common atrioventricular junction because there has been no growth of the vestibular spine. And note again how that inferior cushion is firmly fused to the crest of the ventricular septum. So what is the consequence of failure of growth of the vestibular spine? The endpoint is that the heart develops with common rather than separate atrioventricular junctions. The aortic root is transferred to the left ventricle, but is no longer wedged between the left atrioventricular valve, which has retained its initial trifoliate configuration, and the ventricular septum. And all of this, I'm now going to show you, is key when we look at phenotypic features of atrioventricular septal defect as seen in its common form. Because the phenotypic features stem from the fact that the heart has retained that common junction because there's been no growth of the vestibular spine. So let's look at those phenotypic features and let's analyze them in the 3 orthogonal planes. So this is one that you're all familiar with. It's another of the beautiful pictures taken by Diane Spicer. This is one of the hearts from the Van Meerop archive in Gainesville in Florida. And there beautifully you see the common atrioventricular junction. But you also see the large space between the leading edge of the atrial septum and the crest of the scooped out ventricular septum. So this is the atrioventricular septal defect. If we look at it from the left side, we can see that by looking at another of the hearts from the Van Meerop archive, again photographed by Diane. This time we've opened the left ventricle in clam-like fashion. So once more you see common atrioventricular junction. The aortic root has made its way into the left ventricle, but is no longer wedged between the atrioventricular junctions as it is in the normal situation. And because of that, we see a second of the phenotypic features of atrioventricular septal defect: inlet to outlet septal disproportion. We can very nicely now see that the superior cushion has been transformed into the superior leaflet left of the common atrioventricular valve. And now we see the inferior cushion that is transformed into the inferior leaflet. And then we see the mural leaflet derived from the left lateral cushion. And in the middle of the heart, we have this large defect, most of which is on the ventricular aspect of the plane of the atrioventricular junction, because the septum itself is scooped out. So let's look at the third of the three orthogonal planes, this time in short axis, and now beautifully, you see the common atrioventricular junction, you see the unwedging of the aortic root, and again, we can see how those cushions have now transformed themselves into the superior leaflet, inferior leaflet, and on the left side, we have this third leaflet. And I'm stressing again this trifoliate configuration of the left atrioventricular valve. Now, you all know that when you see in the clinical setting patients having atrioventricular septal defect with common atrioventricular junction, you see different variants. And you call them partial, and you call some complete. But are there anatomic differences between the partial and complete types? Well, there are, but they are quite subtle. Because if we take a heart with an atrioventricular septal defect and common atrioventricular junction, as I have done here, and we strip away the valvar leaflets, we can recognize the inlet to outlet septal disproportion, but having stripped away the valvar leaflets, there is no way I can now tell you that whether this heart initially was a so-called partial variant or was a complete variant. And in fact, we did a study a long time ago when we looked at the extent of inlet-outlet disproportion in the setting of a common atrioventricular valve, and we compared it to the situation in the so-called ostium primum defect, which is atrioventricular septal defect with separate valvar orifices within the common atrioventricular junction. And you see that there is overlapping of the extent of inlet to outlet septal disproportion. Because when we look at those phenotypic features, we can look here on the atrial aspect, having taken away the atrial myocardium, having taken away the aortic channel, we see beautifully the commonality of the atrioventricular junction. We see the unwedging of the aortic root, and there is the plane of the ventricular septum. And in this particular heart, we have a common valve guarding this common atrioventricular junction. And this is what typically is called the complete defect. But compare that with what is said to be the partial defect, the ostium primum defect. And so in this heart, I've made exactly the same dissection. I've cut away the atrial myocardium. I've cut away the aorta. We're looking down on it from above. And in the so-called partial defect, the atrioventricular junction is just as common. The aortic root is just as unwedged as it was in the so-called complete defect. The difference is that in the plane of the ventricular septum, there is now a tongue of tissue that has joined together the superior and inferior leaflets that bridge the ventricular septum, giving us separate valvar orifices for the right and left ventricles within that common atrioventricular junction. So for me, as an anatomist, when I compare the so-called partial defect with the so-called complete defect, I find no difference in the terms of inlet-outlet disproportion. I find no difference in the extent of wedging of the aorta, because all these variations have the same basic phenotype, namely atrioventricular septal defect with common atrioventricular junction. And what I can now tell you is that what you call the partial defect is no more than a dual orifice within that common atrioventricular valve. But nonetheless, you are all equally well aware that there is variability within the phenotype, and that means that the patients present to you in quite markedly different fashions. So what is responsible for producing that variability within a heart that, to me, has the same basic phenotype? And the variability reflects several things. First of all, the arrangement of the valvular leaflets themselves. Secondly, the way the leaflets are then related to the ventricular and the atrial septal structures. And then thirdly, the relationship of that common junction to the septal structures. I shall concentrate today on the ventricular septum and show you the varying relationship between that common junction and the ventricular mass. And so these are the features we need to concentrate upon that produce the variability within the basic phenotype. So let's come back and let's look again at the overall morphology of that valve that is guarding the common atrioventricular junction. And basically, it has 5 leaflets, but those leaflets can be arranged in such a way that the common junction itself can be divided into separate orifices for the right and left ventricles, which, as I've stressed, is no more than dual orifice common atrioventricular valve. So let me show you the orientation of those leaflets as you see them echocardiographically, looking at the base of the heart from the ventricular apex. So you're seeing the right ventricle to your left hand, you're seeing the left ventricle to your right hand, and now I've put in the plane of the ventricular septum. And let's build up the basic common atrioventricular valve. It has 2 leaflets that resemble the leaflets of the tricuspid valve. So one is positioned rightward inferiorly, the other one is positioned rightward and anterosuperiorly. But then we see the 2 leaflets that reflect the morphogenesis of the lesion, because these are the leaflets that are derived from the superior and the inferior atrioventricular cushions. And in the formed heart, they form the 2 leaflets that bridge the ventricular septum. So they are the superior bridging leaflet, the inferior bridging leaflet. And then the common valve is completed by the leftward leaflet, the left mural leaflet, guarding the mural component of the left atrioventricular junction. And so the space between the superior and the inferior bridging leaflets is the same space that was present when those leaflets were guarding the atrioventricular junction, when it was committed exclusively to the developing left ventricle. They represent the zone of apposition between the superior and the inferior bridging leaflets. And as here, I show you the essence of the common atrioventricular valve. Now, during the evolution of cardiac surgery for patients having atrioventricular septal defect with common junction, much was made of the Rastelli classification. This was one of the great innovations made by Giancarlo Rastelli, the outstanding young Italian surgeon who died tragically early and who worked at the Mayo Clinic. Nowadays, we don't use the Rastelli classification quite so much, but it's very useful in appreciating the arrangement of the valvular leaflets. So let's stick with our echocardiographic orientation of the atrioventricular junction. Let's put in the plane of the ventricular septum, and let's put in the leaflets in so-called Rastelli type C. Because the essence of the Rastelli C variant is extreme bridging of the superior leaflet. And going along with that, there is reciprocal hypoplasia of the anterosuperior leaflet of the right ventricle. And then when we look at the spectrum that Rastelli described as type C going towards type A, we see that it all reflects the extent of bridging that superior leaflet into the right ventricle. So I'm showing you here the rarest type, so-called Rastelli type B, where there is intermediate bridging of the superior leaflet with a concomitant increase in the size of the anterosuperior leaflet of the right ventricle. And then as we move to Rastelli type A, the superior bridging leaflet barely gets into the cavity of the right ventricle, and we have a larger anterosuperior leaflet. I now believe we can extend the Rastelli classification to complete the phenotypic variation that I've shown you in the setting of atrioventricular septal defect with common atrioventricular junction, because it is but a small step to get from the Rastelli A malformation to the so-called ostium primum defect, the presence of the connecting tongue that joins together the facing surfaces of the superior and inferior bridging leaflets, producing separate valvar orifices within that common atrioventricular junction, but meaning that the space between the leaflets in the left ventricle is still a zone of apposition between them. And this is what that left atrioventricular valve looks like when we see it in the operating room. This is one of the beautiful pictures taken by my late lamented friend, Benson Wilcox. And what Ben is showing us is the two bridging leaflets, the third leaflet giving us this unequivocal trifoliate configuration, the left atrioventricular valve, that was there from the outset of development. Because the other essential phenotypic feature of atrioventricular septal defect is that the left valve closes in trifoliate fashion. It used to be considered a cleft mitral valve, but that is not true. It has never been a mitral valve. It can never become a mitral valve. The space between those leaflets, those bridging leaflets that we see in the left ventricle, is a zone of apposition between them. We now know from long surgical experience that it is usually necessary to close that space during operative correction so as to make the left valve competent, but it does not alter the nature of the valve. It is still a surgically repaired trifoliate left atrioventricular valve. So what are the other features that determine the differences in phenotypic variability? And perhaps the most important is the relationship between those leaflets and the septal structures, because it is this feature that determines the potential for shunting across the atrioventricular septal defect, which can be at atrial level, at both atrial and ventricular level, rarely exclusively at ventricular level, but sometimes no shunting at all. And we can see this variation very easily when we take the heart in four-chamber fashion. There is the atrioventricular septal defect, and when we put in the bridging leaflets. And if the bridging leaflets float, then there will be the potential for shunting at both atrial and ventricular level. But if we take those bridging leaflets, and if we attach them to the crest of the scooped out ventricular septum, as I showed you in the mouse hearts with so-called ostium primum defects, then shunting through the atrioventricular septal defect is exclusively at atrial level. Whereas, if the leaflets are attached to the underside of the atrial septum, we still have an atrioventricular septal defect, but now shunting will be confined at ventricular level, still with a common atrioventricular junction, and still with a trifoliate valve. Very rarely, the leaflets can be arranged in such a way that they fuse spontaneously to close the atrioventricular septal defect, leaving us a septated heart, but with a trifoliate left atrioventricular valve. And then remember the third feature, the relationship between the junction and the ventricular mass, and that is responsible for ventricular imbalance. And when the arrangement is such that the right ventricle is dominant, then there is typically alignment between the septal structures. The key to ongoing treatment then is the area and the dimensions of the left side of the heart. We can also, however, have left ventricular dominance, and this is the consequence of incomplete expansion of the atrioventricular canal. We can also see this in the separate setting of separate atrioventricular junctions, because this variant is directly analogous to straddling of the tricuspid valve. So what I have shown you is that the phenotypic feature of the commonest form of atrioventricular septal defect is the commonality of the atrioventricular junction. You can rarely have atrioventricular septal defect with separate atrioventricular junctions that direct the Bode defect, but that is exceedingly rare. So nowadays, when we talk about atrioventricular septal defect, then the default option is the lesion that we've been looking at with junction. What I hope I've shown you is that the variations that you see clinically depend on the relationship of that common atrioventricular junction. The valves within it can produce separate orifices, usually leave common orifice, the relationship to the septal structures, which determines the potential for shunting, and then the relationships of the common junction to the ventricular mass, giving us left ventricular or right ventricular dominance. And all of these features, I hope you will now appreciate, are readily understood by what I've shown you with normal and abnormal cardiac development with, for atrioventricular septal defect, the key feature being development of the vestibular spine. So that is our look at atrioventricular septal defect. I've tried to relate it to development. If you stay with us and you see next week's presentation, we'll take a similar approach to ventricular septal defect to complete our survey of septal defects.
Thank you very much, Dr. Anderson. It was amazing. As usual, we learned a lot. We have some people who raised their hands, so we are going to allow them to talk now, and then they can make their question live. So Laura Alves, if you wanted to unmute. You have Ana Paula Santos and Laura Alvarez who raised their hands. If you want to make your questions live, it's just unmute your microphone. And we have Taman Hassam as well. You can unmute your microphone and make your question live. Okay. While no one wants to speak, we have some questions. There was a question talking about the intermediate AVSD. If you have any comment about that, Dr. Anderson.
I dislike the intermediate form intensely because there is no such thing as an intermediate form. The variations, as I've described, are either the level of shunting or else the presence of a common valvar orifice, separate valvar orifices for the right and left ventricles. And so if you describe that, then usually the common orifice goes along with both atrial and ventricular shunting. And then the separate orifices, the ostium primum defect goes along exclusively with atrial shunting. Rarely, as I explained, you can have only ventricular shunting with, again, separate valvar orifices. very rarely you can have separate valvar orifices with minimal ventricular shunting. And that's what some people call the intermediate defect. I think it makes much more sense to call that separate valvar orifices for the right and left ventricles with limited ventricular shunting. So I think that by describing what you see, you take away the uncertainty as to what is an intermediate defect. Because what I've emphasized, the phenotypic features, the commonality of the atrioventricular junction, the inlet-outlet septal disproportion, the unwedging of the aorta, they are just as obvious and just as complete in the so-called partial defect, the so-called intermediate defect, as they are in what is called the complete defect. And so that's another reason why I don't think this notion of an intermediate defect makes any anatomical sense at all.
Okay, thank you. And Paula, do you want to open your microphone? I saw that you were unmuted. Do you want to unmute and ask your question? And Mohammed Fauzi wants to make a question as well. Mohammed, if you want to make your question.
Yes. Hello.
Hello.
Hi, we can hear you.
Thanks, Dr. Anderson. I want to ask.
He's gone.
Yeah, we lost him. Oh, what a pity.
Does he come back again?
Okay, good.
Again. You have to unmute, Mohammed.
Hello. Hello.
Now we can hear you. Yeah, now we can hear you.
Now he's gone.
Is there any? Okay, you hear me?
Yes, I hear you.
Yeah. Is there any embryological or anatomic basis for the abnormal subvalvular apparatus that can we see in the complete AV canal? I mean, like short chordae or single papillary muscle.
Well, we know that the leaflets and we know that the tendinous cords are derived from the trabecular component of the ventricular mass, and the trabeculations also come together to form the papillary muscles. So normally, in the setting of common junction, they retain the supero-inferior position. They don't rotate like they do in the normal heart. So that's why you get them positioned laterally within the left ventricle. And usually they provide sufficient tension apparatus for all of the leaflets. And I think the reason why you would have an abnormal tension apparatus would be abnormal molding and abnormal transformation of those, the trabecular meshwork of the ventricular wall into the papillary muscles and into the tension apparatus. You can get exactly the same thing, in fact, when you have abnormalities of the mitral valve. So, for example, the so-called hammock lesion or the arcade lesion is incomplete transformation of that myocardial component of the tension apparatus into the tendinous cords. And the same way as you have the so-called parachute muscle, where the papillary muscles fuse together. So you can get that for normal mitral valve. You can have a similar situation in atrioventricular septal defect. Why it comes about, I don't think we know that, but maybe in the fullness of time we'll learn what's going on. It's probably to do with genes, but as yet, as far as I'm aware, we have no indication as why it should take place, but it takes place in the setting of the mitral valve. It can also take place in the setting of the trifoliate left AV valve in atrioventricular septal defect.
Thank you a lot.
And Diego Vilar wants to make a question as well. Diego, just unmute your microphone, please. Okay, while Diego is coming in, there's a question that we always have about the conduction system.
What's the question?
And the position of the conduction system on the AVSD.
Well, the conduction system reflects the commonality of the atrioventricular junction. We know that initially the connection between the ventricular myocardium and the atrial myocardium is through the bundle of His. And when early in development, that is at the crux of the heart. When you have failure of separation of the atrioventricular junctions, then it remains at the crux of the heart. One of the variations is when you have incomplete expansion of the atrioventricular junction, which, as I explained, is analogous to straddling of the tricuspid valve. And in that situation, the conduction tissue stays with the malaligned ventricular septum, but the connection is always inferiorly at the point where the muscular ventricular septum comes up and meets the atrioventricular junction. Usually that is coincident with the atrial septal component, but it can, as I say, it can be deviated when you have left ventricular dominance.
Okay, there's a question about when you have only the cleft of the AV valve. Is it related to this defect or not?
The cleft of an isolated mitral valve is found in the setting of separate atrioventricular junctions. The reason that you get the cleft is, of course, because the superior and the inferior cushion, when they come together to form the normal mitral valve, they form the aortic leaflet of the mitral valve. And then you have, in the setting of the normal mitral valve, you have a much larger mural leaflet. So the mural leaflet of the normal mitral valve guards 2/3 of the circumference. The cleft then points into the subaortic outflow tract, because part of normality is the transfer of the aortic root into the left ventricle between the aortic leaflet of the mitral valve and the left ventricular aspect of the septum. It is totally different when you get atrioventricular septal defect with common atrioventricular junction, and that is why the zone of apposition between the left ventricular component of the bridging leaflet should not be called a cleft. It has developmental affinities to the cleft of the normal mitral valve, but in the setting of the common atrioventricular junction, it is the space that has continued to exist between the left ventricular components of the two bridging leaflets derived from the atrioventricular cushions. So it's been there from the outset, and it should not be considered a cleft. It is the zone of apposition between the left ventricular component of the two bridging leaflets.
Okay, so they're two different things. Very, very nice to know that. Diego, do you want to make your question? Just unmute your phone. There's another question, very interesting. What happens with the orifice of the coronary sinus when we have AVSD?
The orifice of the coronary sinus does not necessarily change in its orientation. The coronary sinus occupies the left atrioventricular junction. It retains that position. And indeed, the coronary sinus typically runs along all the way the back of the left AV junction and comes in at the base of the where the atrial septum meets the ventricular septum at the crux of the heart. If you have a persistent left superior cable vein, then the orifice is larger, as it is in the setting of the normal heart. So basically, the coronary sinus retains its normal position. It has not being brought forward, which is what happens when the vestibular spine brings everything forward and fuses the two junctions together. It retains its position at the crux of the heart, inferiorly relative to the common junction, but still running within the left atrioventricular junction.
And there's one question about how do you explain the origin of the Epstein abnormality when we have AV canal,
the Epstein
AVSD? Yeah.
Well, indeed, the Epstein malformation in atrioventricular septal defect, the inferior bridging leaflet comes across the septum. In the so-called ostium primum defect, the inferior bridging leaflet confused with the superior bridging leaflet, and both of them then come across the septum, and they are initially adherent to the right ventricular aspect of the septum. If they don't delaminate, then you would have Epstein's malformation with apical displacement of the hinge line of the superior and the right ventricular components of the superior and inferior bridging leaflets. So it's exactly the same mechanism that accounts for Epstein's malformation in the setting of separate atrioventricular junctions. And I've only ever seen Epstein's malformation in the setting of AVSD in when there are separate junctions for the right and left ventricle. I don't think you can have Ebstein's malformation if you have AVSD with common valvar orifice, but the mechanism is the same. It's the lack of delamination of the cushions from the right ventricular aspect of the septum.
Okay, perfect. I think Mohammed has another question.
Dr. Anderson?
Yes.
Have you noticed any relation between the Rastelli classification and the ventricular imbalance in AV canal? I mean, we saw a lot of cases of
it's a good question, because there is in fact an association. When you have double outlet, when you have AVSD in combination with either tetralogy or with double outlet right ventricle, then always, in my experience, there is Rastelli type C with extreme bridging of the superior bridging leaflet and a large interventricular component extending up towards the ventricular outflow tract. So I've never seen Rastelli type A in association either with tetralogy of Fallot or double outlet right ventricle. So that is the typical association between the Rastelli lesion and the associated defects.
Perfect.
Thank you very much.
Sasha, I think we are on our time, right? It was a very, very nice session. Very
Yes.
nice. And if you want to wrap up, Sasha.
Yes, thank you. That's amazing. There is a lot of questions, Bob. We can stay one day answer to all the questions. I think it was fantastic. We are people. The comments are amazing. We have people from Sudan. We have people from Nicaragua, from Brazil, Argentina. Every time I want to stress this point because I think that this is the real most important point, and this is the philosophy of the academy. Try to keep all the people updated and education, continuous education from our platform. So we thanks again, Professor Anderson. We will see next week. We have in program a lot of things to do with Professor Anderson. We are planning to do page by page of the book from Professor Anderson. People need this. So again, thanks to everybody, and see you very soon with all the activities. Thank you very much.
Bye-bye, guys. Thank you very
Bye.
much.
Cheers to everybody.
Yes.
Bye.
Bye.